a lot of these patients, at least, what I see in my practice is this multi-level disease. They might have fem-pop disease and tibial disease and or pedal disease. And so, how do you approach tandem disease? I mean, you have this patient, let's say they have their digit looks gangrenous. So, it's not a small ulcer, and they have, both tibial and pedal disease. How do you approach that patient?
So, I think this is an interesting discussion because I think, me and you and all of our people that we know in this world go to a lot of the same conferences, hear a lot of the same things. And this comes up quite often, like how much is too much or how much is enough. And I know we don't have a great predictor right now on the table, but for me and the patient population I see, it's get everything done that I can at that time. Mm-hmm. Most of these patients have enough things going on. Half of them, I'd say, are on dialysis. So 3 days of the week, they're stuck in a chair. Then the other 2 days they have left for their doctor's appointments and if I have to do something. So bringing these patients in, staging them, doing one thing, see how they progress for the next few weeks, then doing another thing. When you're at tissue loss, for me, if I can achieve inline flow with, some type of perfusional satisfaction, as far as I can tell, and non-invasive improvement on the spot, that's my goal. That's not always achievable because you might run into, a above the ankle intervention that takes a long time. And if there's any clinical concern for the patient or something else, that's fine. But if I can accomplish everything in that setting and the patient's safe and we're okay, then that's going to happen. That's the ultimate goal.
I completely agree with that. I mean, we talked about, actually when we talked about our tibial intervention back in the day on BackTable, some people would say, oh, just do one tibial artery and then get a Dodge. But we both talked about how we just try to do everything we can. And I think that's really important for these patients to really establish that flow to the wound.
I think it's important because think about it, like we do active wound care clinic and we're doing debriding wounds, initial staging and treating them. And these patients, some of them have go in there for months every week. It's almost like a weekly dialysis session almost. They're coming in for debridement once a week. So if you do one intervention and you wait a few weeks, that's just continual process for them where you're just waiting and waiting. It's like the wait and see tribe. And I don't think that's the best if you have the ability to achieve more at once. Then, because if you do an intervention above the ankle and you have disease below, if you don't improve that disease below, the concern is your outflow going to affect what you just did? Mm-hmm. And I think that's what we're learning more, that if you don't improve that outflow now, your intervention may not do as well. That's what we're trying to tease out and figure out. But just theoretically and in my mind, it makes more sense.
It makes total sense. I mean, we've definitely seen our interventions higher up not be as durable when our outflow sucks.
We say this with like when you do like covered stents in the SFA and PUP, we say the outflow matters, the outflow matters. Well, the outflow below matters for the rest of it too. So
exactly,
you get like a stopgap or a water hammer and you're not going to get much success.